Hello, everyone, and welcome to this presentation on methamphetamine-associated pulmonary arterial hypertension, education, awareness, and dialogue. On behalf of the steering committee, I want to welcome you to this very important presentation. I am Dr. Vinicio de Jesus Perez. I am professor of medicine at Stanford School of Medicine. With me as part of the steering committee who helped put together the presentation that we are discussing today is Dr. Stephen Shoptaw, who's director of the Center for Behavioral and Addiction Medicine at UCLA, and Dr. Julio Mesa, addiction and family medicine physician, who is faculty at the David Geffen School of Medicine at UCLA.
Learning objectives. Describe the epidemiology and clinical characteristics of methamphetamine-associated pulmonary arterial hypertension, meth-PAH. Explain the current understanding of the pathophysiological mechanisms linking methamphetamine use to PAH development. Identify key screening and diagnostic approaches for early detection of methamphetamine use disorder in patients with PAH. Summarize a comprehensive approach to the treatment of meth-PAH that seeks to integrate pharmacotherapy for PAH and substance use disorder management. Look for the purple stars to see the answers to the pre-test questions.
Now that we have completed this section, let us start with an overview of meth-PAH. PAH, as a disease, is a cardiopulmonary condition with no cure. The idiopathic form is characterized by high blood pressure in the pulmonary arteries with no identifiable cause. Secondary pulmonary arterial hypertension develops as a consequence of another known medical condition. This can be left heart diseases, chronic lung diseases, connective tissue disorders, congenital heart defects, and chronic blood clots in the lung. In these conditions, we can see a combination of pathological findings such as fibrosis, inflammation, in situ thrombosis, pulmonary remodeling, pulmonary vasoconstriction, all of which result in a progressive RV strain and dysfunction, which ultimately leads to failure and eventually, without appropriate intervention, in the premature demise of the patient. Now, methamphetamine associated PAH is a unique form of pulmonary arterial hypertension. Methamphetamine use can lead to pulmonary arterial hypertension. What that means is that methamphetamine can cause pulmonary arterial hypertension. The first report of meth-PAH was in 1993. Meth-PAH is associated with a lower 5-year survival rate, an event-free survival at 5 years of about 47% versus 64%, which is seen in idiopathic pulmonary arterial hypertension. Society, psychological, and clinical aspects can complicate the diagnosis and treatment of meth-PAH, and this makes this condition stand out compared to IPAH and other associated forms of PAH. The graphic illustrates the known medical complications associated with chronic methamphetamine use. In addition to pulmonary arterial hypertension, other possible medical complications of chronic methamphetamine use include dilated cardiomyopathy, coronary vasospasm, arrhythmia, atherosclerotic coronary artery disease, catecholamine toxicity, and vasoconstriction. Let's go over a case of methamphetamine PAH. In this case, this is a 50-year-old male with a 3-month history of bipolar disorder presenting with anasarca, dyspnea, and presyncope. The patient is currently on lamotrigine and citalopram. On physical examination, the patient has tachycardia, ascites, plus three-leg edema, cardiomegaly, and cold extremities. Kidney function, oxygen saturation, and blood pressure are stable. The echocardiogram shows an RVSP of 110 millimeters of mercury, a right atrial pressure of 20 millimeters of mercury, severe RV dilation, and a ejection fraction reduction with septal bowing, and preserved left ventricular size and function. There's a mild pericardial effusion noted, and the right ventricular FAC of 15% and a TAPC of 1.2. The diagnostic workup is negative except for a positive urinary tox screen that is positive for amphetamines. When probed, the patient states daily use of methamphetamine for 15 years to treat bipolar disorder, self-treat. After diuresis, the right heart catheterization shows a mean PA pressure of 60 millimeters of mercury, a wedge of 9 millimeters of mercury, pulmonary vascular resistance of 10 Wood units, and a cardiac output cardiac index of 2.8, 1.2, respectively. What are the symptoms of meth-PAH? Meth-PAH patients tend to present with a more dilated and dysfunctional right ventricle, higher right atrial pressures, and worse hemodynamics compared to the idiopathic PH patients. The clinical presentation itself is similar to what you see with other forms of pulmonary arterial hypertension. These patients present with shortness of breath, especially on exertion, fatigue, and reduced exercise capacity. They can also experience chest pain or discomfort, which is as a result of reduced blood flow and heart strain. Patients can also present with peripheral edema and ascites. They may experience palpitations or irregular heartbeat. In advanced stages, the patient may also present with episodes of syncope. And on physical examination, the patient may demonstrate signs of right ventricular failure, such as jugular venous distension and a prominent right heart impulse. Respiratory complications related to methamphetamine use that may accompany PH symptoms also include pulmonary hemorrhage, pulmonary edema, acute lung injury, and pneumothorax. These are particularly prominent in patients who inhale the medication, thus leading to direct damage to the lung tissue. Let's talk about the demographics of meth-PAH. Meth-PAH occurs across all ages group, but based on our current demographic data, the diagnosis is increasing in peoples between 35 and 49 years old. Med-PH occurs across socioeconomic groups. Most people have lower socioeconomic status. Females have a higher relative risk of developing PH than males. However, people with MET-PAH are more likely to be male, younger, and on Medicaid, according to hospitalization data. The figure on the right side illustrates the cumulative incidence of PH diagnosis per 1 million hospitalized patients with and without methamphetamine use. And you can see that the diagnoses are significantly higher independent of the gender of the patient. The prevalence of MET-PAH versus other forms of PAH is also starting to become more well known across the community. What you can see is that MET-PAH is most common in the US West, even distribution across other regions. This data is from the study by Colitis and colleagues in 2021. However, I want to emphasize that while the West has the highest prevalence, it is not exclusive of the West. You can see that across the map, there is evidence of MET-PAH. In the US claims database, you will see that Of all cases of PAH, 10% are associated with methamphetamine. Of those, 64% are treated, 36% untreated. 0.7% of the US population had used methamphetamines in the past year. This is in 2016. Use increased overall and in subgroups with frequent disorder use between 2015 and 2019. And the US use is more prevalent in people who co-use opioids, cocaine, ecstasy, MDMA, heroin, and LSD. In this data from the National Survey on Drug Use and Health, what you can see is that the use of methamphetamine between 2015 and 2019 has increased substantially. Any met use increased by 43% in 2019. People admitting to frequent use increased to 66%. Methamphetamine use disorder diagnosis increased to 62%, and the use of methamphetamine without injection, 105%. This leads me to remind the audience that methamphetamine administration is not limited to the intravenous route. It can be inhaled, it can be swallowed, it can be absorbed by contact with any mucosal surface, it can be introduced rectally. There are many ways to get methamphetamine in the body, all of which can trigger the risk for medical complications.
Section takeaways. Meth-PAH is associated with a lower 5-year survival rate compared to idiopathic PAH. Meth-PAH patients tend to present with more dilated and dysfunctional right ventricles, higher right atrial pressures, and worse hemodynamics compared to idiopathic PAH. Methamphetamine use is increasing in the US, and regionalization of meth-PAH will likely change over time.
Let's now go to our second section, Pathophysiology of meth-PAH. What causes pulmonary arterial hypertension to develop in the context of methamphetamine use? There are many mechanisms that have been proposed, none of which has been clearly demonstrated to be the one or the ones that ultimately create the condition. Pathogenic factors that have been hypothesized to lead to the PAH include activation of the serotonin pathway, increase in oxidative stress, an increase in vasoconstrictor imbalance, genetic susceptibility factors, vascular pathology that develops as a result of that exposure, and cardiac toxicity leading to direct cardiac tissue injury and ventricular dysfunction. Even though we don't have a mechanism or mechanisms that are truly demonstrated to be causative, we do know enough that to establish that met use causes pulmonary hypertension, which is why in the 2024 proceedings from the Seven World Symposium, methamphetamine is considered to be a definite association with PAH in the same way as aminorex, in the same way as dasatinib, in the same way as fenfluramine and the other agents. In other words, there is no argument that using methamphetamine causes pulmonary arterial hypertension. How does methamphetamine work once you take it? Well, in this study by Volko and colleagues, they use a radiolabeled methamphetamine to see where the methamphetamine goes once it is administered. The highest peak concentration was in the lung and the kidney. The fastest uptake was lung and then the heart in 55-60 seconds. The fastest clearance was in lung and heart. And this is what's interesting, 33% higher lung uptake in African Americans versus whites. No difference in other organs. So, a couple of things to unpack here. Number one, methamphetamine has a affinity for the lung. Once you take it, regardless of the route, the lung is going to see it. It's going to see it quickly and it's going to try to metabolize it quickly. Number two, there may be some genetic susceptibility factors associated with ancestry that may play a role in how a patient responds or metabolizes the drug. Whether this has a particular impact on the risk of developing pulmonary arterial hypertension with MET remains to be resolved. Let's talk a little bit about serotonin and PH pathogenesis. Serotonin is a well known player in the development of all forms of group 1 PAH, particularly in the context of idiopathic, hereditary, and drug induced pulmonary hypertension. So serotonin transporter is implicated in PH pathogenesis, and methamphetamine acts as a substrate for the serotonin transporter protein. It works like that in the brain, which is part of its mechanism for leading to excitation and awareness. The level used illicitly might be high enough to increase levels of 5-hydroxytryptamine, which may lead to a state of higher endogenous serotonin. The effect of serotonin on the pulmonary circulation is that it triggers the proliferation of smooth muscle cells, leading to vascular remodeling and arterial narrowing. On the right, you actually see a graph that summarizes the serotonin cycle, starting with tryptophan as a source of serotonin and ultimately the biology of serotonin as it's involved with interaction with surface receptors, as well as intracellular transportation through SERT. So it is known that serotonin levels are elevated in the blood of patients with PAH as well as with drug induced PAH. Hypoxia, an environmental stimulus that is known to trigger vascular remodeling by itself, can be a trigger for meth induced PAH. Evidence from animal and cell based models show that hypoxia and methamphetamine together can confabulate to trigger changes in the DNA, leading to DNA damage, which ultimately may affect the capacity of the cell to proliferate, generate energy to the mitochondria, ultimately leading to dysregulated cell growth and vascular remodeling. As indicated earlier, methamphetamine use, the effects are not only limited to the lung, but they affect the cardiovascular system in general. While we focus on the lung circulation, it is worth noting that we have evidence of direct endothelial damage, vascular smooth muscle proliferation, even development of accelerated atherosclerosis in the systemic circulation as a result of inflammatory responses, which ultimately lead to a pattern of progressive endothelial apoptosis, smooth muscle proliferation, and a phenotypic switch that ultimately results in obstructive vascular remodeling, which raises pulmonary pressures and triggers heart failure. The same can actually happen on the left side of the heart, and it is not rare to actually see patients who present with biventricular failure. They have pulmonary hypertension, they have right heart failure, but due to the methamphetamine, they also have direct damage to the left side of the heart. And these, of course, are complex patients, which presents with features of both group 1 and group 2. And as you can imagine, these are incredibly challenging to manage. Methamphetamine can also induce cardiac fibrosis, inflammation, electrical remodeling, increased QT prolongation, and arrhythmia risk. Methamphetamine can promote mitochondrial dysfunction and dilated cardiomyopathy via catecholamine and direct toxicity. And this is a mechanism that can also be seen with other stimulant-based cardiotoxicity, for example, in the context of cocaine-induced cardiomyopathy. So all in all, you can imagine how a patient that's abusing multiple stimulants together could be at a higher risk of these entities, and also implies that there may be molecular pathways that are sharing common with this. But it is also likely that methamphetamine as a different compound has unique mechanisms that cocaine doesn't have. At this point in time, cocaine is not considered a definitive risk for pulmonary hypertension, but methamphetamine is. So this implies that while the medications can trigger vascular and cardiovascular injury, the mechanisms involved are different for both. Our group recently identified a genetic susceptibility factor, a gene that encodes for a protein called carboxyl esterase 1 or CES1. This is a protein that serves in the endoplasmic reticulum, and it is primarily involved in drug detoxification, similar to the cytochrome family of proteins. Carboxylesterase 1 also is a lipid protein involved in processing triglycerides. In the context of mutations that affect the capacity of CES1 to carry out its activities, it is known that patients have trouble metabolizing compounds. But in particular, CES1 is involved in inactivation of amphetamines, cocaine, and heroin. So in terms of drugs of abuse, you need intact CES1 to be able to neutralize these toxins. Most S1 variants target conserved residues in the active site that may reduce enzymatic activity. What does that mean? It means that if you carry a mutation that reduces the activity of CES1, or if the levels of CES1 expression are below normal, you may actually have, and you're using methamphetamine, the levels of methamphetamine may remain elevated for much longer, which means that you may experience a more prolonged high, but at the same time, your vascular cardiopulmonary system will experience longer exposure, potentially triggering a higher burden of injury. Whether that may be the mechanism or a significant contributor to the risk of pulmonary hypertension remains to be determined. So, to summarize what we have learned in this second section, the takeaways for you all are that serotonin transporter is implicated in PAH pathogenesis, not just methamphetamine, but PAH in general. Serotonin stimulates the proliferation of pulmonary arterial smooth muscle cells, leading to vascular remodeling and arterial narrowing. Methamphetamine causes acute vasospasm, and chronic use leads to endothelial damage and pulmonary hypertension. And variants in CES1 can have implications for the inactivation of methamphetamine, contributing to meth-PAH. Now let's move to screening and diagnosis. Screening PH patients for meth-PAH should follow a protocol that's in line with the current guidelines for the diagnosis and screening of PAH, with some additions. All patients with PAH should be screened for meth-PAH regardless of regional prevalence of methamphetamine use. What does that mean? It means that you should always ask patients directly whether or not they're using or they have used methamphetamine. That is the most important thing. So regardless of where you practice, you should always make a point of asking. And this is very sensitive information. And in a moment, I will share with you some approaches that can help you break the ice and reach the patient so that you can have the patient share this, since this is a sensitive subject, as you can imagine, for many patients. Now, some patients, in my experience, can actually arrive to your clinic and they may exhibit signs of acute methamphetamine use. What does this mean? These patients can present with an increased burst of energy, euphoria. They have excessive talking, they're sweating, they grind their teeth, they have tightened jaw muscles. Physically, you may see that there is a substantial weight loss. Patients may have trouble sleeping. In some extreme cases, patients may experience psychotic symptoms such as hallucination, paranoia. They may have tension, excitability, somebody who cannot stay seated. They're jumping around while they're talking to you. And some patients following what is called the crash, when the drug levels drop, they may become suicidal or severely depressed. So conduct screening and follow up whenever possible, regardless of continued methamphetamine use. What that means is that, independent of whether this patient continues to use methamphetamine or stops methamphetamine altogether, as you take their case and continue to provide care, always remain supportive. There's some barriers to identifying these patients that you should be aware of. Access to transportation, so these patients may not be able to assist to all appointments because of lack of transportation. There are suspicions regarding the engagement to the care group. Their own socioeconomic status can also limit their access to insurance. Lack of stable housing. Some patients don't have a house, they are homeless, and that limits their capacity to meet the appointments or perform tests. The lack of familiar and caregiver support is a huge problem, and this has significant implications on deciding the best treatment for that patient, as we will talk. And for us, and the reason why we are sharing this lecture with you, is that for many clinicians, there is a lack of awareness that methamphetamine can trigger PAH, which is why asking the question of whether the patient has used methamphetamine or not is such an important part for you to add to your approach when assessing patients. Now, this is something that I hope will serve you well, because as a physician myself, taking care of these patients now for more than 20 years, I have learned how to approach patients. It's not easy to talk with patients about sexual habits, high risk sexual activity, or use of drugs. This is something that is very sensitive, and even if the patient is no longer using the medication, they're likely embarrassed and anxious about talking to this. So these are some tips that I would like to share with you, which I think have been helpful to me and others who see these patients often. Set the context. Always approach the patient in a non-judgmental, matter-of-fact manner. You say that if this is a routine assessment, you ask everyone, independent of whether they're 80, 90-year old, independent of male, female, LGBTQ or not. You will ask everyone on exposures of factors that could impact lungs and blood vessels. Use open-ended, non-judgmental language. Have you ever used any stimulants like methamphetamine, even if it was a long time ago? The tone is really important. You have to make it balanced. Try to avoid strong inflections. This is a statement. Let the patient build on that. Acknowledge past use. Once a patient shares with you their use, this is a sign of trust. And I think you need to be very grateful, because this is giving you the opportunity to truly help this person. The person is opening themselves to you, and this is how you can build a long, constructive, and effective medical partnership with this patient. So thank you for sharing that. It's helpful for us to understand all potential contributors so we can give you the most accurate diagnosis and best care possible. Completely non-judgmental. You're being very matter of fact. You are doing your job. Explain. Education is key. Patients may not necessarily know that methamphetamine is the cause of their pulmonary hypertension. So, the more education you share in a non judgmental manner, the more likely the patient is going to gain that insight that will ultimately help them get on with your recommended program. The screening and consent is also important. We often do routine screening, including lab tests, to check for substances that might affect the lung. Will it be okay to include that as part of your workup? So, offering to do a urinary tox screen is going to be important because it's important to document whether the patient is using methamphetamine and continues to use the methamphetamine. It has to be documented on the record. I mean, methamphetamine use disorder is a medical condition. And as physicians, it's our responsibility to make sure that the medical record is accurate and updated. And finally, and this is probably the most important thing that I'm going to encourage you all to consider, is to maintain empathy. No matter what we find, our focus is on helping you feel better and making sure your treatment is right for you. It can be easy to get frustrated with patients that have addiction disorders, but at the end of the day, your job here is to help them in the best possible way and not impart judgment. As long as the patient hears that your goal is to ensure their well being and help them through this ordeal, it's likely the patient is going to partner to you and they're going to be following your directions moving further. The diagnosis of meth-PAH is a diagnosis of exclusion. You need to rule out all other potential etiologies. So meth-PAH remains underdiagnosed. And again, I think a major reason for that is that we are not routinely asking patients about this. So I'm sure that as we become more aware of this entity and start asking patients and documenting in the chart this, it may become more obvious that this is a more prevalent disease than what we have thought so far. So, meth-PAH established when pulmonary arterial hypertension diagnosis is made and methamphetamine use is identified as the principal risk factor. At this point, you have done everything that the current diagnostic algorithm has recommended. Methamphetamine users with progressive exceptional dyspnea should be promptly evaluated for PAH. Now, this is important for colleagues who work in primary care or are in addiction medicine settings where they're taking care of these patients. As alluded to, methamphetamine can cause a variety of medical complications, PAH being one of them. So I think if you have a practice whereby you see patients with methamphetamine addiction and they're presenting with shortness of breath or swelling, you should strongly consider ordering an echocardiogram to see if you can identify some of the signs that may lead you to perform a thorough pulmonary arterial hypertension workup. The initial screening should include a demographic and drug use data, a standard 12-lead EKG, measurement of biomarkers like BMP, NT-proBNP, a 6-minute walk test, an echo, and a toxicology screen, urine or blood. The diagnosis is based on established hemodynamic criteria: a mean pulmonary arterial pressure greater than 20 millimeters of mercury, pulmonary arterial wedge less than 15, a pulmonary vascular resistance greater than 3 Woods units, although more recently this has changed now to 2 Woods units, and excluding all other causes of pulmonary hypertension like left side heart disease, lung disease, thromboembolic disease, or group 5 classes. There are, of course, diagnostic challenges. Again, this is a very unique and challenging form of pulmonary arterial hypertension. Again, this is a diagnosis of exclusion. So, as such, it will be ideal if we had a clear definition. But a Delphi panel that was assembled for this purpose could not agree on a definition for meth-PAH. So, the current proposed definition is that group 1 PAH in a patient with a history of methamphetamine use. The problem, and many of you are probably wondering, is well, how much use do you need to have before you can consider that the patient's pulmonary arterial hypertension is because of that? And that is a big unknown. In the studies that our group has conducted, we have used an exposure of minimum of 3 to 6 months, but this is based on definitions used in other studies where drug-induced pulmonary hypertension has been assessed. Whether that is what is needed for methamphetamine to cause the disease, completely unknown. Remember that these patient populations are heterogeneous, so and there may be genetic susceptibility factors. There also another question we get asked a lot is about whether the route of delivery makes a difference? These are great questions for which we currently do not know the answer. And also remember that met use can also lead to problems in the left side of the heart. So all of a sudden you may actually have a overlap between group 1 and group 2, which complicates diagnosis, but most importantly may also complicate the response to the therapy that you may offer these patients. So these are still ongoing open questions that we need to properly address to get a better understanding on what the best practice for diagnosis and treating this patient should be. If I were to show you under the microscope what the lung vessels of an idiopathic versus a meth-PAH patient look like, it will be hard for you to tease out. They are similar. This is a plexiform lesion. As many of you know, the pathognomonic lesion in pulmonary arterial hypertension. In meth-PAH, you see these lesions in the same way as in idiopathic. There's nothing in these lesions that can help you tell one from the other. Sometimes you may see foreign objects stuck in them, like talc crystals, and again, that could potentially raise suspicion that this may be the mechanism for the PAH of the patient. But as to how that plays a role in the development of the condition, completely unclear. But what we do know is that, again, if you look over 10 years, and you control for age, sex, socioeconomic status, education, and you compare patients idiopathic meth-PAH, you will see that the patient with meth-PAH has a worse survival, and this is associated to worse hemodynamics and right ventricular function compared to the idiopathic patient. Many of these patients, when you take them to the right heart cath, some of you will do an angiogram, which helps you look at the anatomy and distribution of the pulmonary arteries in these patients. Under normal conditions, you will see that when you inject contrast, you see a nice blush at the level of velar capillary. In PAH, what happens is that, as you see here on the top panels, tortuosity of the vessels and less alveolar perfusion. With meth-PAH, you see exactly the same. There's really no way to tell apart idiopathic versus meth-PAH on account of the angiogram. So, all in all, the pathology and the morphological, like the vascular morphometry of meth-PAH is identical to that of idiopathic, which again is the rationale for why this condition is placed in the group 1 together with IPAH.
Section takeaways. All patients with PAH should be screened for meth-PAH. Be alert for acute symptoms of methamphetamine use and ask patients explicitly about use. Diagnostic approach for meth-PAH is the same as for other forms of PAH. Patients may have features of WHO groups 1 and 2 PAH. Meth-PAH is established when a PAH diagnosis is made and methamphetamine use is identified as the principal risk factor.
Let's now talk about treatment strategies. The treatment of meth-PAH. The cornerstone of clinical management is the cessation of methamphetamine use plus standard medical regimes for idiopathic PAH. No studies have evaluated the efficacy of therapy specific to meth-PAH. Studies usually include patients who have idiopathic, familial, drug-induced, and within the drug-induced, we may see some methamphetamine, but there's really no study that has only used meth-PAH. Nationally, 30% of people with meth-PAH are not receiving treatment for PAH. This is in a 2022 study that we hope to be publishing soon. But you can see in the map across the United States, you can see the diagnosis of patients with pulmonary hypertension associated with MET, and the numbers, the percentage tells you how many people in that state with a diagnosis of MET-PH are actually getting the pH therapy. And you can see that there's a wild difference that ranges from in the west side, for example, in California, you get 72% of these patients are getting therapy, whereas in some areas of the East Coast, you may actually have 34%, 48%, even 27%. So these are trends that are concerning, and it's important for us in the long term to understand what are the reasons why these patients may not be getting therapy. And it's likely that this is incredibly complex, but it is likely a public health emergency to understand this, because we got patients out there with a very severe form of pulmonary hypertension that are not getting proper therapy. And our goal is to be able to address this and provide these patients with the same level of care that the other patients are receiving. The standard of care, of course, is the complete cessation of methamphetamine use. This, of course, is more complex. Not every patient that you tell that they should stop will be able to stop, because this is part of the addiction cycle. And we'll talk a little bit in a moment about what we can do about that. Many of us, pulmonologists, cardiopulmonologists like myself, we're not trained to deal with addiction. So this is actually why it's going to be really important for you to assemble a multidisciplinary group that involves addiction specialists. And we'll talk about that in a moment. But when it comes to what you will offer the patient, remember, these are patients who technically are group 1, so you should be able to consider every single FDA approved therapy, from ERAs, PD5, soluble guanylate cyclase stimulator, prostacyclin analogs, even sotatercept. The management of right heart failure, comorbid conditions, psychosocial support, referral to lung transplant should all follow standard pH protocols. These patients do tend to have a diminished response to acute vasoreactivity, so calcium channel blockers are generally not very effective. However, if a patient does meet vasoreactivity criteria, they should be offered a calcium channel blocker. There are no clinical trials ongoing for meth-PAH specifically. No medications have FDA approval for stimulant use disorder, and no medications that might be FDA approved within the next 5 years. That's a challenge. Delphi Consensus Panel agreed that patients with meth-PAH should be included in meth-PAH only trials, post-drug approval trials, and subgroup analysis. One of the greatest challenges, as you probably have gained awareness by now, is that we need data. And I think this is actually one of the biggest challenges that we are hoping to address in the next coming years. The Delphi consensus statements have some recommendations for the treatment of meth-PAH. People with meth-PAH can be treated according to the same guidelines as people with idiopathic PAH. These people who are actively using methamphetamine should be treated. Adjust drug choices and administration route as needed. What do we mean by that? If the patient is actively using meth, you still will treat that patient. Do not hold back treatment because the patient is actively using meth. You should, however, consider which therapies you're going to offer that patient, but you should not withhold therapy for that patient. The factors that influence treatment choice involve comorbidities. Remember, if a patient has left sided disease, that can influence your choice of therapies. The reveal score. If patient who has high risk is somebody that you may want to treat very aggressively. A patient that has HIV as a result of intravenous drug use of high risk sex activities, which are likely to be higher in the context of methamphetamine use, that comes with another bag of complications and the need for therapy. Treatment related, make sure that you consider carefully the side effect profile, route of administration, the geographical location, and most importantly, the patient related factors. Compliance, the use of the methamphetamine. Is the patient coming to the meetings? Is the patient responding to mails? Is the patient picking up the medications from the pharmacy? Are they engaged with social and caregiver support? Are they participating in a substance abuse program? Do they have stable housing? What's their mental health psychiatric conditions? Think about it. One of the most important examples I usually give is you may actually have a patient that has a high risk reveal score. They may have severe right ventricular function. They come to the hospital, you will treat them aggressively, which may include an IV prostanoid. However, this patient may not have adequate social support to manage a pump on their own. They may still be using methamphetamine. So there's a myriad of factors that ultimately will make you concerned that if you send this patient out with a pump, this patient may be at risk of complications, anywhere from infection to disconnection. This is an issue. And while the best treatment for that patient will be a pump because of the severity of the disease, it also comes with a lot of risks. In that particular case, again, you will not withhold therapy, but you will need to find alternate therapies, such as maybe switching the patient to an inhale, to an oral, perhaps sotatercept. Again, this is where the decision of how to treat these patients becomes challenging for the clinician. But at the same time, we have to think for what's best for the patient. And all of these factors here are part of that decision process, which ultimately that this is a shared decision that you need to make with the patient based on their needs, their resources, and ultimately what you want, which is to get this patient treated and give them a chance to have a better quality of life than what they currently have as the result of their condition. So, if we go back to that case I presented to you, we started that patient on upfront sildenafil, macitentan, Flolan, and then weaned the patient to oral therapy and subcutaneous remoduling. The patient comes back 3 months later with a positive UTOX, so still using, and severely depressed. Denies any improvements and admits to suicidal ideation. Optimizing treatment adherence. Simplify the regimes, minimize dosing frequency, number of daily pills when possible, and favor therapies with less administration burden. Sequential. Start with fewer agents, prioritize building trust, then escalate once reliable adherence is established. Education and engagement. Proactive patient education tailored to health literacy, clear communication on therapy goals and side effects. Every time you sit with the patient, talk with them, emphasize again the importance of coming to the encounters, taking the medications, doing the testing. Integrated care. You need to involve addiction specialists, social workers to address addiction recurrence and psychosocial barriers. I cannot emphasize this enough. I, as a physician, I'm not trained to deal with all the psychosocial burden as well as the addiction burden. I am not trained. I am trained to take care of the patient. So it is essential for me to bring these experts to care and to create a multidisciplinary team where ideas are discussed, challenges are addressed, and a plan is made that integrates the best efforts and expertise from each group. And finally, make sure that accessible support systems are in place. Anything that can facilitate transportation, pharmacy access, medication reminder, peer support can go a long way. How do we treat meth use and methamphetamine use disorder? Behavioral therapies are the primary and most effective current evidence based treatments. It has shown benefits in reducing methamphetamine use, and long term effectiveness is limited by moderate retention and high relapse rate after treatment ends. So it's not perfect, but it can be effective. There are no medications with FDA approval for treatment of methamphetamine use disorder. So all options are off label. The strongest pharmacological evidence is for the combination of bupropion and naltrexone. Mirtazapine reduces methamphetamine use, but does not lead to abstinence. And antipsychotic and sedatives can address the stimulant toxicity, but again, they have limited success in maintaining abstinence. So, again, the approach is to be non judgmental, understand the pattern of use and how the patient is using the medication, explore the benefits and harm of use with the patient, use the DSM-5 for diagnosis, and offer a motivational interview. Again, engaging the patient, engaging their goals. Reducing use will require withdrawal management. There is withdrawal associated with stopping the use of methamphetamine, similar to with opioids and other medication. Make sure you have non-pharmacological interventions in place. Some of the things that are recommended by our colleagues in addiction medicine are contingency management, cognitive behavioral therapy, matrix model, residential rehabilitation, and transcranial magnetic stimulation. Pharmacologic management, again, is not FDA approved, but it can be useful in many cases. So, use of mirtazapine, bupropion, and naltrexone, and sustained release methylphenidate, particularly in those cases where patients may have undiagnosed ADHD and are using methamphetamine to self treat. The data for bupropion and naltrexone, this combination has the strongest evidence for methamphetamine cessation, and they do have a synergistic effect. Bupropion at a dose of 450 milligram has a substantial effect of a weak stimulant, so it can take away some of the rush associated with methamphetamine, while naltrexone produces significant dose of full mu opioid antagonists and kappa opioid antagonists to reduce some of the cravings that are associated with the drug. You can see in this study over 16 weeks that compared to placebo, the combination of naltrexone and bupropion had the highest percentage of methamphetamine negative urine test. Other medications, you can see data here for mirtazapine, again, does not lead to abstinence, but it does reduce methamphetamine use. The mechanism is unknown and potential downside, and we see this with other conditions for which mirtazapine is used, is a significant weight gain. The other medications, such as psychostimulants, GABA, opioid medications, again, they have a role for the management of acute psychosis or neuroexcitability, but less so in terms of short and long-term methamphetamine cessation.
Section takeaways. Methamphetamine cessation is the cornerstone of managing meth-PAH. Strongest evidence for methamphetamine cessation is with bupropion plus XR naltrexone. Treatment of meth-PAH follows the same principles as treatment of other forms of PAH. Patient Education Resources, SAMHSA National Helpline. Free, confidential, 24/7, 365-day-a-year treatment referral and information. English and Spanish. For people facing mental or substance use disorders. More resources at samhsa.gov.
So, key takeaways from this presentation is if you're going to take home something, please know that prevalence of methamphetamine use and meth-PAH are increasing in most regions of the United States, and that the most important thing you can do is you should ask your patients if they are using or have used methamphetamine in the past, how much, by what route. Try to document that. Diagnosis has to be confirmed by right heart catheterization, and you have to rule out any other potential cause before you can attribute this to meth. And methamphetamine cessation combined with guideline-directed therapy for PAH remains the foundation for managing these patients. Thank you very much for attending this seminar. Please complete your CME assessment to receive credit for attending this presentation.